Hi, everyone. Welcome to today's webinar. This is Community Level Interventions to Address ACEs, Successes and Lessons Learned. And it's part of the 2020 Research in Progress webinar series on preventing adverse childhood experiences and child maltreatment. So thanks for joining us today. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health, where I work with the Program for Injury Prevention, Education, and Research, also known as PIPER. And this webinar series is brought to you by the National Peer Learning Team on Child Maltreatment, which is a national network of people working in public health and social services who come together to learn about primary prevention approaches to child maltreatment and ACEs. And the NPLT is funded by the Centers for Disease Control and Prevention, and it's a partnership between PIPER and the Colorado School of Public Health and the Colorado Department of Public Health and Environment. So we're really excited to be here today for the 7th in our series of Research in Progress webinars. And thank you very much for joining us today. I'm going to do a little housekeeping before I introduce our speakers. So please use the Q&A feature to ask any questions. You'll see the Q&A option in your Zoom controls. And I encourage you to put your questions in throughout the presentations, and then we'll have time at the end to field those questions for the presenters today. We are recording today's session. The link will be available along with the slides after the session on our website, and we'll email that out to everyone that's registered for today's webinar. And also at the end of the webinar, a feedback survey will pop up for you. And please just take a few moments and give us your feedback on today's webinar and any ideas for future speakers that you'd like to hear from or topics that you'd like to hear about as we continue to plan these for the future. I want to let you know about our past webinars, which are posted on our website. And these cover a range of topics that you can see here: policy approaches, exploring some data around household challenges and early childhood ACE scores, gun violence, organizational policies to prevent sexual abuse, a variety of topics that we've covered over the past year in our series. And you can get more information and watch the recordings of these on our website, with the exception of the last one on promoting economic stability. That recording we'll be able to post hopefully in the coming weeks, but it's not yet available. We always like to do a little bit of information gathering from our audience. So I'm going to do a couple of polls here for you today. First, if you could let us know, if you're attending today's webinar, what is your level of understanding of community-based approaches to addressing adverse childhood experiences? To give us a little level setting of who's joining us today. Are you completely green with this topic? Are you an expert on this topic? So I'll give it a moment for people to answer the poll. Okay, great. So most folks have voted. Looks like 66%. So the majority said I have some basic knowledge. And then we have 30% with a solid background on this topic, and smaller numbers for being completely green or being an expert. So great. So thank you for sharing that. And I have a second poll here about what type of organization do you work in? So are you coming from public health, social services, medical care, nonprofits, research institutions, K-12 education? I see lots of responses coming in on these. Okay, excellent. So let me share these results. So 33% coming from public health. And then it looks like behind public health, we have nonprofits and social service agencies, but a real mix of different organizations that we have represented here today. Well, great. Well, that gives our presenters a little sense of who's joining us today. And now I'd like to introduce them and thank them so much for coming and sharing their work with us today. So first we have Dr. Jen Leiferman. She is a professor in the Department of, and the chair of the Department of Community and Behavioral Health at the Colorado School of Public Health. She's also the director of the Rocky Mountain Prevention Research Center, and she's spent the last 20 years working in the area of population mental health. Her current research focuses on developing and testing prevention and treatment strategies for perinatal and child mental health. So welcome to Dr. Leiferman. And then also Don Hanna, who's the director of the PALS Children's Program of La Puente. He also serves as a pastor in the Presbyterian Church, USA, and spent years in the church as a children and youth director and pastor. He and his wife spent over a decade raising children from foster care and have a son adopted out of foster care. And they live on a family ranch in southern Colorado that was established in 1887 and has been in his family for 5 generations. And we're very lucky to have you both here today to share your work with us. And I want to just remind our attendees to put your questions throughout in the Q&A, and we'll have time at the end for those. But now I'd like to turn it over to our presenters to share their slides with us.
Great, thanks, Sarah. So I think I will be going first, and then Don will follow. So let me just grab my slides here. Can everybody see these? Yes?
Looks great.
Okay, thanks. Okay, so I'm Jen Leiferman, and like Sarah said, I'm from the Colorado School of Public Health. And in our Rocky Mountain Prevention Research Center, we have a core research project called STANCE, Linking Systems to Address ACEs in Childhood Early On. And I'm here to share what we've learned so far in this project and to tell a little bit about the CDC structure with the Prevention Research Centers, and then our partnership with the San Luis Valley. And Don Hanna, he resides in the San Luis Valley, and he's on our community advisory board for our Prevention Research Center. So he'll finish our presentation really talking about a neat program aimed to help families who have had a considerable amount of ACEs. So first and foremost, I want to just acknowledge the investigative team on this core research project, my co-PI, Dr. Ginny Puma, and then we have co-investigators, Betsy Risendahl, Glenn Mays, Beth McManus, Danielle Varda, and study coordinator Dave LaRocca, and a great team with Marlena Martinez and Angela Haney in the Valley, who's really helping to do the heavy lifting with this project. So a little bit about the Prevention Research Center. So the Center for Disease Control and Prevention fund prevention research centers across the country. They're in schools of public health or schools of medicine. And it forms this network that plays this vital role with the public health system. Each PRC identifies a public health problem and has a particular focus, but we all work together. The prevention research centers across the country work together to disseminate our knowledge and what we learn, and any trainings or information to really help disseminate what we're finding out at a center level and getting it through the network for the broader public health impact. So our center is called the Rocky Mountain Prevention Research Center. It's the only prevention research center funded by the CDC in Region 8. And our mission there, you can see, is to really help children and families across the Rocky Mountain region who live in communities where health equity is achieved by optimizing social, emotional, mental, and physical health. Most of the projects that we have in the center focus on enhancing the well-being of families, especially with young children. Think early prevention, so from pregnancy through age 5. So every PRC works closely with the community, and our community partners with San Luis Valley. And you can see this great picture here. These are some of our CAB members who have really worked with us, some for decades. And the Community Advisory Board works closely with our center as we develop programs and implement projects in the Valley. And they were instrumental in identifying the STANCE project and helping us step by step along the way in the development and soon to be evaluation of the project. The Community Advisory Board came off of a year of learning before we submitted our grant to the CDC for this 5-year project and as our core research project. And they identified ACEs as a priority issue for the Valley. And most of us on the call here know ACEs, adverse childhood experiences. These are traumatic experiences that can have a profound effect on a child's developing brain and body, has lasting impact on a person's health throughout the lifespan. There are 10 recognized ACEs. They fall into 3 types: abuse, neglect, and household dysfunction. You can see on the slide there examples of household dysfunction include things like substance abuse in the home, parental separation, divorce, mental illness, etc. So they came off of this year learning, thinking about the community, what were the areas that they felt needed to be addressed, and identified ACEs. And the reason why is because ACEs are very prevalent. And we can see some data here from the CDC ACEs study that's well known, as well as more recent data from the BRFIS. And what we find from these more population level data sets is that people report having 2 or more ACEs, 16% of people. And when we look at 3 or more ACEs, it's 9.5% of the population, and 4 or more ACEs at 12.5%. And we recognize in the San Luis Valley that these prevalence rates were similar there, if not even a little higher. And what we also know is that there's this graded dose response relationship between ACEs and negative health outcomes. In particular, we see that ACEs are linked to many health risks for alcoholism, drug abuse, depression, suicide, and many chronic health conditions. What really stands out is those individuals who have 4 or more ACEs are at a much greater risk. So you can see some of the data here, like 12.2 times more likely to attempt suicide if they have experienced 4 or more ACEs, 10.3 times likely to use injection drugs, 7.4 times likely to be an alcoholic. And then we look at the chronic disease, 2.4 times likely to have a stroke, 1.6 times likely to have diabetes. So there's definitely a negative health impact from ACEs, and that gets even stronger the more ACEs you're exposed to. What this means at a societal level, we see some data that with those individuals who've had even 6 or more, we see a reduction in life expectancy by 20 years. And the economic toll for the country, it's very high, and it can be across these sectors, from productivity to healthcare expenditures, to special education needs, child welfare, and the criminal justice system. So there's a clear need to think about what we can do to help families who have experienced ACEs. And we decided, with the partnership with our Community Advisory Board in the San Luis Valley, that the prevention of ACEs was going to be our priority area. So we wrote this grant to the CDC to think about what would be some ways that we can help the San Luis Valley come up with a framework to try to prevent the intergenerational transmission of adverse childhood experiences, with the hope that if we can learn how to do something effective in the San Luis Valley, that we could take lessons learned to other communities. And we know from the literature, you can see on the slide, there are some key ways that we can prevent ACEs. This is well established. We can focus on changing social norms to support parents and positive parenting, the economic supports to families, quality education early in life, enhancing parenting skills to promote healthy development, and then intervene to lessen harm and prevent future risk. Thinking about all of that evidence and knowing these strategies that could be employed, we worked closely with the Valley's Community Advisory Board to develop STANCE. This is a multi-level intervention within a systems framework aimed to reduce the occurrence of adverse outcomes related to ACEs. The goal of the project is threefold. We wanted to figure out, how do we reach our families who have great risk for ACEs? And we identified early child education centers. This is going to be the hub for STANCE. we're going to work with early child education centers in the Valley. So we have 16 early child education centers that have signed up to be a part of STANCE. We're in year 2 of it, of the project. And the project is multi-level. The first level is we're going to work in the early child education centers to screen families who have had ACEs, and then really work on linking them to the appropriate care. The second thing we're going to do is direct intervention programming. We're going to work with the ECEs to implement evidence-based programs to promote social emotional competence and development in kiddos. And the last thing we're going to do is work in the Valley to enhance those linkages in the community for wraparound services for our most highest risk families. So let me break this down step by step. So the first thing we're doing is we're working with these early child education centers to screen families on ACEs as well as BACES, so the Benevolence Childhood Experience Survey. We want to get a better understanding of who's at risk, and we're doing this in a really sensitive way. So we will assess ACEs, not having families list out every ACE they've experienced, but just say how many they have, because remember the dose response. So we want to really identify those families who are at greatest risk. But all families who we screen will get resources that are available in the community. The parents who screen high on ACEs, they actually will get referred to a behavioral health consultant who will meet with them to talk about the supports that they have and further explore resources that they may need. They also have an opportunity to complete an app. So we've worked with VNL and Visibility Network Laboratory, and they have a social networking app that they've developed so that the parent could take this app and it helps them identify their own network around them for resources and social support. And in doing that app, it helps the behavioral health consultant talk through what are the needs of the family, and then hopefully helps enhance that linkage to care. The second level is that direct programming. So we will be working, or we are right now currently, in these 16 ECEs, and it's a step wedge design. So we'll slowly roll the intervention out in some ECEs this year, and then we'll roll it out in more ECEs next year, and then the following year. And these intervention early child education centers will receive the Pyramid program, which is an evidence-based program that really helps teachers do trauma-based approaches to promote social emotional competence and development in, again, young kids. The other thing it does is we will have parenting workshops, the Positive Solutions program. And so these workshops will further strengthen parenting skills and knowledge to promote that social emotional competence in kids. And so the goal here is to equip young kids with the mechanisms to navigate environments that may not always be healthy, so that we can again try to break the cycle of this intergenerational transmission of ACEs. The last piece is, it's very important, and I think first and foremost for us when we even thought about doing this program, is that we think about that wraparound services. What does the community actually offer for resources for these families at high risk for ACEs? And so we partnered again with VNL. They have a partner tool that is a social networking tool. And this tool allows us to see how are the organizations that serve families who are at great risk for ACEs communicating and working with one another. We have some preliminary baseline results that I want to share with you briefly. We administered this survey right after the pandemic hit. The timing couldn't have been any crazier, but we really wanted to make sure that we better understood what the community has at that point, so that we can work with them over the next few years to strengthen any areas of need as far as the way the communication's happening across these broader sectors. So Don's going to share a lot more about the San Luis Valley, what it's like, the beautiful community there, both geographically and just with the wonderful warm people. But we want to see kind of where we're at. So we're in the southwest part of the state here. We did a survey with our partners. We had a 75% response rate. We asked organizations, again, serving our families at great risk for ACEs. These would be organizations that fall into healthcare, education, public health, criminal justice, and social services. We asked them to complete this survey to better understand who are they serving, and again, how are they connecting with the other organizations that serve these families. You can see here the San Luis Valley has 6 counties. These circles here represent, did they serve all 6 counties? So the yellow would be an organization that serves all 6. And then if they served one or a couple different communities or counties, they would be color coded there to the right. So here's just some brief, just to whet your appetite, if you will, on the data. We have a lot of data, but we wanted to find out what is the awareness of ACEs for these organizations. And not surprisingly, a lot of them are very aware or somewhat aware. There still is room for growth, though. There was a percentage here that we want to move in their awareness of ACEs. The next thing is, what are the outcomes of their community relationships? And the main reason they like to collaborate and connect with one another is to the exchange of resources and information, which is what we had anticipated would probably be the case. How successful do they think the community is in addressing ACEs? You can see that to the left, they don't think it's as successful as it could be. So we have room for growth. Our goal is to take the baseline data we're looking at now, and in the next few years, work with these organizations to enhance the communication and exchange of resources and really strengthen the trust and level of reciprocity across these organizations. So what are the barriers? Well, financial resources, not surprising. But the second one, which is modifiable or easier to modify, is this poor communication and lack of trust. So that is our number one goal right now. Like I said earlier, is that we're going to work with these organizations and try to really strengthen the trust, so then that we can open the gates to have more transference of data and information and knowledge and just overall better care for these families. Did COVID impact the quality of services, the frequency of services? For the most part, no. So hopefully that's still the same case. We did do this right after the pandemic hit, so that might have changed since then, but hopefully not to that great of extent. What did the organization say? What was their top priority? Linking children and family support services. Everybody, for the most part, was on board, felt like that was a high priority, and then to identify any barriers at the systems level that we could address. You can see there's a few others there: increasing awareness, increasing evidence-based interventions in early child education centers. I'd like to thank Visible Network Labs for helping us do the social networking analysis. We have a full report that's on our website if you'd like to get all of the data from this baseline survey. I just briefly, before I pass this over to Don, I just wanted to highlight just where we are with next steps. So the STANCE project will continue to implement the 3 levels that we went through today. We're going to work with our community organizations to strengthen that network of care, invest in those relationships, identify ways that we can help leverage current resources, and figure out pathways to work together. And we'll continue to collect our data for another 3 more years. And then the STANCE project is 5 years, and the last year is really geared to think about what have we learned in the San Luis Valley with STANCE, and then begin to think about disseminating that into other communities. And last, one of the other things we're doing in addition to STANCE in the San Luis Valley is thinking about how can we work closely with our community partners to implement and evaluate additional programming to address ACEs. And Don, Hannah, and I have, we've collaborated on a grant that's funded by the CDPHE that really works closely with Don's organization, PELS, that he's going to share with you. And it gives you a little example of the great work being done in the Valley on the ground to really help these families who are at great risk. And so just one thing for you all to see before Don, I pass to you. Here is our website for the Rocky Mountain Prevention Research Center. And we can maybe show this up at the end again, but if you want to get the full report on the data, we can get that to you. And then we have a ACES resource page that will be coming up online in the next week or two that might be of help to some. So thank you. I guess we'll hold any questions for the work I presented. And Don, I look forward to hearing more about the program.
Okay, well, let's see. Okay, well, I guess I'll start off. I understand that people are coming to us from around the country, so just to give a little bit of setting for where we are and where the work is being done. San Luis Valley, as Jen mentioned, is in South Central Colorado, and it's a place of great beauty and great isolation. Great beauty, you can see these pictures here are actually my backyard and my front yard. So you can see both the beauty and the isolation. It's a heavily agricultural area. It's an area that is about the size of Massachusetts with a population of only 50,000 people, and about a fifth of that all in one town kind of on the east side of the valley. So it acts as an economic hub and center for the valley. But as you can probably hear in that, an area the size of Massachusetts with a town that's 9,000 people as its economic hub, there's a lot of poverty. Got a little infographic here. The median income is about $29,000 for the valley. 1 in 3 kids grow up in poverty, heavily reliant on food bank network. 90% of the kids here qualify for free or reduced lunch. And with poverty, that begets things like just crisis, homelessness. In terms of Colorado, often Alamosa, where my program is, the PALS program, we're often in the top 3 as far as counties for abuse and neglect. And we've been really hit hard also, as a lot of the country has, with a meth and heroin epidemic. So that gives us just a little picture of where we're at. A little bit about the program. So as I mentioned, we're an area that's got a lot of poverty. About 30 years ago, there was an organization that we're a daughter to. La Puente is a homeless shelter, and it started, like I said, about 30 years ago, and it's evolved a lot over the years in response to community needs. And so following the homeless shelter, there were a lot of people who were coming into the shelter who were, in a situation where they're stable enough, where, something had happened where they just fell on hard circumstances and had become homeless. And so to address that, the La Puente started another program called Adelante, and that program was transitional housing. It's changed a lot over the years, which I won't go into now, but for many years it was transitional housing, getting families in particular from the shelter into stable housing. And so one of the big needs that developed out of that, as they were trying to move families into housing, was if someone was going to it was often single parents, if they were going to get a job to be able to afford housing and they had kids, childcare was a big issue. And so there was a volunteer who started watching kids in the Adelante program, and that was how my program, the PALS Children's Program, was born. I just started with one program, watching their kids as they were going to work. And it's grown a lot since then. One of the things that kind of developed out of that, families that were in the shelter, the kids that were being watched were kids who had experienced some pretty hard things in life. Like maybe they were in the shelter because had been some domestic violence in the home, or maybe drug issues in the home, or whatever the situation. And if nothing else, just being homeless was a trauma for kids. And so as the program developed, it really started, I guess, tailoring a bit for kids who had trauma, and probably before anyone was recognizing ACEs as a thing in this area anyway. But the kids who were coming into the program were coming in with high ACE scores. Eventually, about 10, 15 years ago, I guess about 15 years ago now, our local DHS Child Protection started saying, hey, the kids that you're working with are also the kids that we're working with, and so we contracted with DHS, and so about half of our kids now are coming in through Child Protection. All of our kids are referral based, and we've opened up referrals so that we take referrals from the school, from again DHS, from behavioral health, from the Boys and Girls Club if they're having kids that they're seeing behavioral issues with that they're struggling with. We'll take referrals or medical providers as well. Many of our kids are coming in. Jen had mentioned the 4 or more ACE scores. It's pretty atypical to see kids coming in with fewer than 4 in our program. And I've had kids that are coming in with 8 or 9 points on that ACE score. We see kids who are coming in with drug issues in the home, domestic violence, neglect, mental health issues in the house, sexual traumas. When I started the program, there were 4 kids in the program who had been present when one parent had attempted murder on another parent. So the kids have been through a whole lot, and as a result, the behaviors that we see are a lot. We get a lot of defiance, pretty extreme meltdowns, violence towards staff or violence towards one another. One of the things that struck me, if you're familiar with the positive-based interventions and supports, the PBIS system, they talk about this pyramid where they say, if you're doing this, 80% of your kids should be just covered, should behave well given these structures. And then you'll have 15% kids who might need a little extra support, and then 5% where at the very top of this pyramid where you're going to need to put in some pretty intensive interventions. And I was at a training with that, and one of my staff members leaned over and said, yeah, that top pyramid, those are all of our kids, pretty much, and maybe dipping down into that second tier a little bit, but for the most part, we've got that top tier. And so it can be a pretty hard and stressful place sometimes. But the program, I think, as I came into it, there was a lot of great stuff happening. We have a pretty high staff to kid ratio. We had 5 staff for every 4 kids. And there was consistency and scheduling, and we had all these fun opportunities. However, as I entered, I became the director about 4 years ago, and I felt that despite all of our best intentions there, sometimes it felt like we were really just glorified babysitters, that we were missing a lot of opportunity, big opportunity, in that we weren't using evidence-based practices as much as we could. And there was some trauma-informed care, but just had a lot more to go on that. So I started digging into that and trying to steer the ship in that direction. It was about 3 years ago when I found TBRI, that's a trust-based relational intervention. It's an evidence-based intervention for working with kids. And what I found is that really it was truly amazing. If you're working with a kid, it worked like magic. You could just see them, the behaviors go away. You could see the kids' trust being built, and it worked great in a one-on-one setting. But as we're in the larger group, things would tend to fall apart. If there was me and 3 other kids and one kid was acting up, and I was trying to use trust-based relational intervention to work with this kid and pull him out of a meltdown or stop a behavior or something, the focus would not be on me. The focus would be on the other 2 kids there. So they were paying attention to peers in a program where there were so many kids with trauma. They might be triggering each other or working each other up or just feeding off of each other's energy. And so, I found like I was always banging my head against the wall and asking our TBRI consultants, what to do in this situation. I've got, we were told in trauma informed care, if a kid just doesn't have it in them at the moment to sit in the circle, it's probably not good to try to force them to do that. And so to allow a space so that they can get cooled down or that sort of thing. And so we would do that, and then we would have another kid do that and another kid. And then, with 20 kids, pretty soon it was 3 kids in the circle and 17 kids walking around, and they weren't cooling down anymore. They were working each other up. So there were lots of difficulties as we were trying to move from a situation where we were working hard on keeping control to a situation where you're being more trauma informed. And a lot of the answers that we were getting, it seemed like they would work in a kind of a, in quotes, normal classroom where there was the critical mass. Just kind of a side story. I remember going to a birthday party for my daughter, and the parent there who was organizing said, "All right, kids, we're gonna have dinner now. Let's get in line." And every kid at that party just got in line, and it just blew my mind because I've been working with my pals for so long, and if we say get in line, it's kind of herding cats, and it just doesn't happen that way. So stuck out. So I guess that leads me up to the start of COVID. COVID hit, and we shut down with the rest of the world for April this year. And when we opened back up, just to be in compliance with the 10 people, we started with 5 kids a day. So we had 5 on Monday, 5 on Tuesday, 5 on Wednesday, 5 on Thursday, and then took Friday to organize and sanitize and all that sort of thing. And so we had 5 staff and then 5 kids. So every kid had a staff member, and probably not surprisingly, just the behaviors went way down. We were able to give these kids intentional care all day long. And it was amazing. It was a totally different place. As we moved from April into May and the restrictions were loosened up a little bit, we went to 10 kids every other day. And as we did that, we were very careful in selecting what 10 kids were together, trying to avoid having kids who worked each other up or triggered each other being in the same group. And really, we didn't see a whole lot of shift in behaviors from when we had 5 kids to when we went to 10 kids. Things were still going pretty well. And it really opened my eyes to what we had been up against with too many kids with too many issues, and just having this higher staff to kid ratio was making such a huge difference. Well, then right around that time, somewhere in there, Jen called me up and talked about this grant that was being put out by the Colorado Department of Health and Environment that was available to study ACEs prevention, and put together a proposal, and we were able to get it. So with that, I think I haven't been advancing slides as I should have been. With that, we were able to expand our one-on-one interventions, hire new staff, help kids with a tool called the DESA, which is the Devereaux Student Strength Assessment. We have this thing called Crash and Bump that's put out by the TBRI people where you intentionally work kids up with fun activities as kind of a bit of an obstacle course, or a ring of behaviors where they get a bounce on a jumpaline, and then you go through regulation exercise and calm them down. You get we got some moon shoes, and then they work on regulation exercise or just stuff like that. And then also part of PALS for a long time, for a number of years, is that we've been trying to take the kids on some trips just to expand their worldview and let them dream bigger dreams. We go to science museums and we go to national parks. We've been to like Yellowstone National Park or Zion National Park. Been climbing at climbing gyms and things like that. And most of our kids, while we don't have any, there's no income requirement for joining the program. You could be a doctor's kid, and if you've had trauma and have these behaviors, they would be welcome into the program. The program is free to any of the kids in it. What we find is, just because of the area we're in, and also because poverty will lead to situations where ACEs are happening more, that 99% of the kids that we have in our program are really coming out of pretty extreme poverty. And so doing the trips that we do, most of them just won't have any sort of opportunity for those experiences outside of the program. Also, so we have let's see. So with the DESA, the DESA is a assessment tool that works on scoring kids in 8 areas of social emotional competence. And they're here: self-awareness, self-management, social awareness, relationship skills, goal-directed behavior, personal responsibility, decision-making, and optimistic thinking. And so we're able to, once a month, give this test, and it really kind of pinpoints where the kids are struggling. Right now we're finding that it really is a lot of self-management and self-awareness that kids are struggling with the most. And so then we're able to tailor our one-on-one interventions to the kid, and really give them goals that we're wanting to achieve with them. The next thing is the parent workshops. When I started the program, it was interesting. I guess the culture of the program was one where parents were often seen almost in an adversarial relationship, or seen as maybe part of the problem. Our kids were coming in with high ACEs, and often those were coming because they were in these households And so we've tried to shift that so that we can work with parents, be more of have more of a partnership with them, working on education and support. And then another thing that we find is, as we're doing intakes with parents, a lot of times as I'm asking the parents about their social connections, who's an emergency contact in case we can't get in touch with you? There's no one. And so, just trying to build some community by having folks together. We're offering workshops, or plan on offering workshops. We've had one on just ACEs awareness, one on using TBRI techniques. I'm gonna do some on resilience, on healthy screen time, on the importance of schedules and nutrition, self-care, and then also do some on service, like a service project with families, as well as taking advantage of the area's great beauty. And then the third part is with the grant is parent-child interactive therapy, and that part hasn't come online yet, but we're excited for when it does. So just as I conclude, I'm really excited. I'm starting to see some of the successes of all this. A couple examples: we've seen a kid who came in June who was completely nonverbal, stuck to himself, very shy, and just in that time worked with them consistently, and now he's talking. And there's one day where he's almost just constantly babbling, and we see him making friends. A couple of things that are a little hard. It can be hard to measure success. So like we always want to see the line just shooting up where you have the behaviors lessening and lessening, but the kids' lives continue to be turbulent. So for instance, we had a family where dad went to jail to be deported. Mom became depressed, wouldn't wake up. The kids started not going to school. And all of a sudden their behaviors are kind of up and down. They did remarkably well, like that would stress anyone out, but you just can't, the line isn't going to go straight up at that point. And I'd also add, just on top of that, COVID, I remember this little kid is going through all this stuff, just venting all of it, and he ended by saying, and a kid at school coughed on me, and now I'm going to get COVID. So, that's definitely in the back of their minds. And then one other thing, just that, sometimes success, I don't think, shows itself as success. And we have a couple of kids who were able to present pretty well, but the longer we're with us, they seem to be in more of a trusting relationship. And with that becomes more demonstration of behaviors. They're pushing us a little more, they're testing boundaries, and I feel like they feel safer, and so they're willing to do that. But then in terms of looking at behaviors and scoring behaviors, they're going down. So we're hoping to see a little turnaround with that as we can continue to work with them. But overall, just really excited. The new data tools are a place where we can make some measurements. I'm excited to see this as a new possible model where we can intervene and then have the kids in a social setting where we can use that social setting as teachable moments and reinforce the interventions. So just really, really excited. And just one thing as we open up for questions, I'd also put out for you that I'm open to all of you. If you have resources, I want to learn as much as I can and do as much as I can for kids. So I have my email up here. If any of you out there have resources that feel like it'd be good for our program, I encourage you to send them our way, and I will leave it at that.
Great. Well, thank you both so much for your presentations and for sharing both sort of the research perspective and what's happening in your community I think that gave us a lot to think about. We have a lot of questions, so we'll try to get to as many as we can. I think, and I'll try to sort of group some of the overall themes of the questions. I think one to start out is, as others who may be listening in on the call think about these kinds of partnerships between research programs and service providers and groups like La Puente nonprofits, how are you approaching evaluation of the overall initiative? Dawn, you mentioned some of the measures that you're looking at for the individual kids, but I wonder if you could speak to sort of how you're measuring your progress in the community and what sort of indicators you're looking at. So that might be for Jen to start.
Sure. So that's a really great question. And I think with all the prevention research centers, there's such a strong community engagement component that you have to come in at it with a true partnership on what's feasible and what's meaningful from research standpoint. So it's definitely a give or take kind of relationship as we set up the evaluation framework. For STANCE, what we decided to do on the direct programming in the early child education centers is just to be thoughtful about what, again, is feasible to ask teachers to complete and parents. And so we worked there to do the social skills improvement system rating. It was something that some of them were familiar with, and we could kind of embed it into the infrastructure. So we're using that to assess our social emotional competence and problem behaviors, which is our primary outcome for STANCE. And then as far as the outer rings and how we're going to be evaluating the social networking, we are using the partner tool, and then we'll do that, repeated throughout the intervention to see change. And then with Dawn and the partnership with Dawn, so the RNPRC is actually partnering with PALS to help with the evaluation, and we meet regularly, and it's really this coming together to figure out what's feasible. We had a kind of a wish list when we came together about what we would really like to do and see for evaluation as far as like the DEXA that he talked about, and then we're evaluating all the different components as far like the workshops and the outings. And we've had to pull back. I think the lessons learned with COVID is what can we do and what we probably really can't do right now because of just the burden on asking people to complete assessments. So we've had to kind of change a little bit here and there as we've navigated, especially with our schools, for both projects, whether they're in person or not, and the level of connection makes some evaluation efforts they have to be modified given the times. But Dawn, do you want to share more on?
Yeah, I guess in terms of quantitative research, that we've got the DESA, which does have, it gives a score for social emotional competencies. We've also at PALS for about a year, we developed a behavior assessment, a positive based behavior assessment, which also gives a score for kids. So we're using those two things to track progress with kids. With the parent workshops, we are doing before and after surveys to see skills, and we have our staff. We're really trying to build up that relationship between PALS and the families, and so every Friday staff are making calls to the parents and caregivers saying, what worked in the workshops and what are you utilizing. So we're trying to do some research that way, and then as the therapy comes online, it'll be how many people took advantage of that and how many completed their therapy and that sort of thing. So those are the measures here.
That's great. Thank you. We got several questions about sort of the community level partners that are engaged with the work. And so I'd like to ask you about that. One attendee asked about advocacy and legislative approaches and whether there's philanthropy partners who are involved in some of the kind of community and policy level changes that might be necessary to change the environment for kids. And so if you could speak to whether you have those types of partners engaged. And then also someone asked about faith communities, and Dawn, maybe you could speak a little bit more about the faith communities involvement at the community level as well.
Yeah, so I can speak, I guess, to the first part. The RMPRC has quite a few different levels of partnerships, and we're really trying to strengthen them. And so partnerships in the Valley, we have been working with an informal coalition, and we went to them at the beginning, to make sure that, capacity was there for identifying families at greater risk. And why I just bring this up is they were currently focusing on older kids in elementary schools, but they had a strong interest in moving into the space for the early kiddos. And so we kind of had that kind of buy-in right, from the get-go, and we've been working with that group. And why that's important is those are the organizations that are on the ground, our stakeholders who really have buy-in for our mission, and we have that shared vision. And so we are working together, to see how we can utilize resources and bring in additional resources on the ground level. At more of an academic partner level, we meet quarterly with partners on campus. And the Kemp Center is a great resource that we have here at Anschutz. And they have worked on a project CareNet that has allocated funds to train providers in identifying child maltreatment. And we've been able to link them down to the Valley. They came to our community advisory board to share more about the potential to have trainings there for our providers, again, to expand just our level of care. So those are just a couple of examples. And Don, I don't know if you want to share on the faith-based organizations.
Well, I guess in terms of the work that like the PRC is doing, on the CAB at the PRC, there is a good representation of health care, some education, and I guess I kind of wear both hats as PALS director and pastor in that. It's probably an area that we could expand more. It comes up in conversation because the Valley is an area where there are a lot of strong ties to churches and faith communities, and so it's a really great sort of informal network where as we're working on especially the awareness side of things, it's probably an area that we should push on more, just to raise awareness. We just came out with this video to raise awareness on ACEs through the PRC, and that was one of the areas of conversation, is like, how do we get this out? And so yeah, just using that informal network is a good idea, but it's probably one that's not very developed right now.
Okay, thank you for those responses. We're almost out of time, but someone did raise this issue that as you know, there's some controversy around ACEs screening and the extent to which the ACEs should be used for sort of individual level screening. And just some questions about how you think about that in the work that you're doing, and if you could maybe provide a little more context about how you're using the ACEs as a screener.
Yeah, this probably we've given the most thought to this out of everything, even when we wrote the grant a few years ago, and then in the last year and a half when we've been in the field. And we have a great state national committee of advisors that have helped us really think through this, along with our team on the ground. And, I think the first thing that came to our mind was we have to make sure we have high response efficacy. So, if we identify these families in need, making sure that we have really strong connections to get them into care. So that was our first and foremost step, was building this network of behavioral health specialists, getting the app so that we can really connect, and making sure that all the resources that are in the app or in our resource guide had capacity. So that was the first thing we did. The second thing is we knew right away that we didn't want to increase the stigma and to bring light, in a negative way. But we also needed to figure out how we could identify them. And that's why we looked at just having the ACEs and just doing a number and not which ones, just how many, to go with the literature, knowing that the higher families were the ones that we really wanted to focus a lot of our time and resources with. And then we included the bases, and part of that was about just reducing the stigma and really shining a light on the strengths that a family has. And our behavioral health consultants actually open it up with, like, what's going well for you? What are your strengths? And so we've worked really closely with our advisors and our national committee to think about how we frame this in more of a resiliency framework, and how we can work from a standpoint of every parent wants to be the best parent that they could be. That's the assumption we're working. So what works well for you? What might you need to help with your parenting, instead of, tabulating every single ACE that you've had.
All right,
Yeah, I guess
thank you.
as the project started off, that was one of the concerns that I had as well, that parents often will come in feeling kind of under the microscope, feeling like DHS is breathing down their neck, or whatever the school is trying to threaten them with truancy, or they feel that the man is too involved, and they get very defensive, and I honestly would be too. And so just I've raised that concern as we started the Stance project, and the PRC did some work with some of the parents and PALs to figure out how to ask questions in a way that we're not trying to make the parents be defensive. And I guess the other thing that I'd mention is, like, just in terms of like the parent workshops that we did, like one of the first workshop we did was on ACEs, and it was trying to help parents understand that there is this generational cycle, and the traumas that their kids do go through have a long-term effect. And so in asking the questions, that it's not trying to pry into their business or anything like that, but it's more working on how can we help get interventions in place for their kids, and as well as help support them and build them up and give them tools. So we've been trying at least to be really intentional in saying, not focusing on negative, but looking future oriented to positive.
Wonderful. Well, thank you both so much. I want to thank you for taking the time and sharing your great work with us today. I know we didn't get to all the questions, but we will send out a follow-up email with contact information. So if you want to learn more about this work or these programs, I would just encourage you all to continue that conversation offline. But again, thanks for joining us today, to all of our attendees, and for the great questions. And thanks to Jen and Dawn for presenting today. And I hope everyone has a great rest of your day.
And again, I'll just put a plug in to email me if you have any suggestions. I'd love resources.
Awesome.
Thanks.
All right, take care.